Okay, good evening, everybody. Welcome to this 14th session of 51st Comprehensive Course on Echocardiography. We are going to deal with diastolic function evaluation as on today in this particular session. And before that, let me have some basic revision for wall thickening abnormalities. That is the most important thing. Second important issue is we'll start with the diastolic function after some time. Once I'm done with this, just a second. So let me show you a couple of examples of cases where you can see a wall thickening abnormalities. To begin with, this is where we are, Jorop Institute of Echocardiography in Delhi. This is our auditorium, and these are the people who are legends behind this echo training program for more than 25 years. You must have been talking to Mrs. Reena Dua off and on for a long time, and we have multiple accreditations in this particular programs. We can boast of saying the only institute in India providing hands-on training for more than 25 years without any break. And we are celebrating our silver jubilee on 17th August 2025 in Delhi in Ashoka Hotel. And we would like to welcome all of you over there. Whosoever can make it, it's a day-long program. And I'll show you the program next week when we meet again. With these few words, let me just present a few cases of wall thickening abnormalities. I'll just take about 5 to 7 minutes before my colleague, Dr. DEBIKA CHATTERJEE, joins for a diastolic function evaluations. So here is a few presentations of a wall thickening abnormalities, which I did a few days back. And I've tried to incorporate this along with the video record, along with the ECG. Now look at this ECG of this patient. All of you will understand there is a poor progression of R wave from V1, V2, V3, V4, V5, and suddenly there is a R wave which is appearing in V6. And if you look at the axis may be a little bit on the left-hand side. What do we expect out of this patient? We expect a possibility involvement of left anterior descending artery or LED territory. Now look at these images very carefully. Now what do you see in these images once they are playing? This part of mid-anterior septum is not contracting. How about this part? So if we take this mid-anterior septum, which is not contracting, and then we went on to see an apical septum, which is also not contracting, is almost thinned out. Look at the basal inferior segment. It's thinned out, hyperechoic. Then we have a two-chamber view. In this two-chamber view, what do we see in this two-chamber views again? We see the apical inferior wall, apical lateral wall, apical anterior wall, mid-anterior wall. They are almost akinetics. If I have to put all these things together and look at the severity of MR, this MR jet is touching all the way to pulmonic veins. And this is what the pulmonic venous Doppler flow pattern is. Look, my pulmonic venous Doppler flow pattern is right into the pulmonic vein. And look at the systolic truncation of the pulmonic venous flow pattern, which I taught you already before. So there's no reversal. So at least we have moderate mitral regurgitation in this particular subject. Now look, go back and see what is the difference in this patient. We have almost akinetic mid-anterior septum. I'm not really sure about this. It looks to be akinetic. Then we have whole of the septum along with apex and apical lateral wall akinetic. Then we have apical anterior, apical inferior wall, and possibly mid-anterior wall akinetic. Evidence of at least moderate MR with systolic truncation of the pulmonic venous flow pattern. And if this segment is not contracting, sorry, what does it mean by? It means by we are dealing with proximal LED lesion. And this one segment, which is supplied by D1 branch of LED, has got a significance in detecting coronary artery disease. So what are the segments involved? Mid and basal anterior septum, apical septum, apical lateral wall, mid and basal inferior wall, then apical inferior and apical anterior wall, along with moderate MR, suggestive of possibly a proximal LED lesion. So let's move another case, almost similar. Now in this image, look, this apical lateral, apical septum, apical and mid-anterior wall and apical inferior wall, they're involved. But you look carefully, this segment is contracting. If this segment is contracting, what does it mean by? It means by that we are dealing with a mid-LED lesion where D1 branch of LED is preserved. So answer is LED lesion again, but distal to D1 branch of LED. And this is what the ECG of the same patient is. We have this ECG of poor progression of R wave up to V3, V4, V5, V6. We does not have any poor progression of R. Now, another segments. If you look at carefully, these wall motion abnormalities, look, apex is contracting very well. Correct? There's something which is lagging behind in this lateral, basal lateral wall. Then, my whole of the anterior wall is contracting very well. How about my apical inferior, mid-inferior? But look at the basal inferior segment, which is poorly contracting. And now the third segment is we go to the posterior wall, look at the mid and basal posterior wall, which is hypocontractile or shows hypokinesis of the function. Answer, possibly we are dealing with circumflex territory in this subset of populations. So these are the few pictures I just wanted to show you. Look, these things makes a lot of difference in your clinical practice. And if you go back to that ECG classically shows that ST segment depression in lead 2-3 AVF, and it is showing at V5, V6. Now there is a poor progression of R wave, but the diagnosis lies somewhere over here in circumflex territory. Last, if you have basal septum, basal inferior wall involvement without any lateral wall, think of an RCA territory. And in those cases, always look at your RV function, because this is the most important function which I taught you. If the RV function is poor, it means you have a proximal RCA lesion. If the RV function is preserved, and if you have a basal inferior, basal septum and basal inferior wall, then think of a lesion which is distal to RV branch of RCA, right coronary artery. And that's what I wanted to share with you today. Before I hand over my mic to Dr. DEBIKA CHATTERJEE, let me have a pleasure of introducing her. She is going to talk on diastology, as I said a few minutes back. She is a senior consultant and cardiologist based at Narayan Hridayalaya, Rabindranath Tagore Institute of Cardiology at Kolkata, and she is head of the Department of Non-Invasive Cardiology. She is one of the ace in cardiology and echocardiography from Eastern India, where she has grown to bigger heights over a period of times. That's all I would like to say for Dr. Debika Chatterjee, and I'll request her to start her presentation, and I'll stop sharing my slides. Dr. Debika, go ahead, please.
Good evening, sir, and good evening, everybody. And Dr. Gupta, thank you for the kind introduction. And so I will talk. And am I visible? Is my slide visible, sir?
Yeah, perfectly visible, perfectly visible.
Okay. So let me start, sir, then, with your permission.
Sure, go ahead, please.
So assessment of diastolic function by echocardiography is a very important chapter in the field of echocardiography. Let me start my presentation with a case who is a 60 years old male, obese, having history of hypertension, complaining of progressive exertional dyspnea with fatigue, with bilateral ankle edema on examination, hepatomegaly, bilateral cramps. So obviously the diagnosis is congestive heart failure. Now, as we get a case of heart failure, we always think, we try to find out the cause. And the first cause which comes to our mind is the patient having systolic heart failure. Well, for that, we do the echocardiography, and what we see that all the segments of the LV, this is the parasternal long axis, short axis, apical 4 chamber, apical 2 chamber, almost I have covered all the walls. All the walls are showing good systolic excursion with good systolic function of the LV. Well, then what it is? So we go further and we do the Doppler echo. We rule out any left to right shunt. We rule out any right heart pathology. But as we do the Doppler for assessment of diastolic function, we see that the patient is suffering from the diastolic dysfunction with elevated LV filling pressure. So what it is, my patient is a case of heart failure with preserved ejection fraction, which accounts for around 40 to 50% of all heart failure, responsible for significant morbidity, mortality, recurrent hospitalization, and prognosis is as bad as systolic heart failure. So we have to know this diastolic assessment of diastolic function to diagnose this type of cases. Whenever a patient comes with heart failure, we need to answer a few questions. We start thinking about these questions. First of all, does this patient truly have the HFpEF, or is the heart failure due to some other cause? Well, if the patient is having HFpEF, how we are going to manage, how we are going to optimize the unloading therapy, and also what is the prognosis of the patient, how I am going to follow up the treatment. Well, all these questions can be answered by assessing the diastolic function of the patient by echocardiography. Because by echocardiography, we not only get an idea about the structural problems of the heart, which may give rise to the diastolic dysfunction, we can also come to know about the functional problems related to the diastolic function. We can find out that the LV filling pressure is high, because it is the final common effect of diastolic dysfunction in the heart. And it is the elevated LV filling pressure which results in shortness of breath in this group of patients. And also, this raised LV filling pressure is a marker of poor prognosis. So as per the latest guidelines of American Society of Echocardiography, grading of diastolic dysfunction is done on the basis of presence or absence of elevated LV filling pressure. So your echo report on diastolic function should mention the status of LV filling pressure, whether it's normal or elevated, other than commenting on the presence or absence of diastolic dysfunction. Now let us recapitulate a bit of physiology of diastole. Now, as you know, diastole starts with aortic valve closure and ends with mitral valve closure. So this is the phase when the heart gets its filling, ventricle gets its filling. So it's the process by which heart returns to its relaxed state. Relaxed state to get ready to receive the blood. Now, if we look at the phases of diastole, well, it starts from the isovolumic relaxation phase. Now, this is the phase when both mitral valve and the aortic valve are closed. Ventricle is taking rest. It is relaxing. It is this phase when the calcium ion is calcium ion is taken away from the sarcomere, as a result of which the myocardium relaxes and the LV pressure comes down. So how long it will come down? See, in the meantime, during the diastole, this phase, the atrium is getting filled up, left atrium is getting filled up with the blood from the pulmonary veins. When LV was in systole, LA was receiving the blood from the pulmonary veins. So LA pressure is high. Now LV pressure has gone down now. It's gone down and gone down till the time when its pressure is lower than the LA pressure, because blood flows from the higher pressure chamber to the lower pressure chamber. So as soon as the LA pressure becomes higher than the LV pressure, the mitral valve opens. And as soon as it opens, early rapid filling starts. The rapid filling starts, and with the Doppler of mitral valve flow, we get a wave called E wave. You see, this is the LV pressure tracing. If you happen to go to the cath lab, you will see this type of pressure tracing. So this is the early rapid filling phase. Around 80% filling of the ventricle takes place during early rapid filling phase, because heart is very compliant and it receives the blood, whatever blood LA is sending. Because of the pressure difference, the LV is ready to receive. LV is compliant and it receives the huge amount of the blood during the early rapid filling phase. Now, as it receives, the LV pressure goes up, and a time comes when the LV pressure and LA pressure becomes again equal, and no more blood. There is no more pressure difference. So blood cannot flow from the LA to LV because of the pressure difference. It is the flow from the pulmonary vein which can go directly to the left ventricle using the left atrium as a conduit. And that phase is called diastasis. This is the diastasis. This is the diastasis phase in the this Doppler spectral pattern, where there is very little flow from the pulmonary vein to the ventricle directly, where LA is used as a conduit. Now, you remember that 20% of the blood is still remaining into the left atrium. Well, how the LV is going for the systole? It is almost ready. Only that 20% blood is left into the left atrium. So now, since there is no pressure difference, LA has to contract to eject that amount of the blood to the left ventricle. So that phase is called left diastolic filling phase. It is due to the left atrial pump, and we get a relatively smaller wave than E wave, because amount of the blood is less, only 20% normally. So A wave is due to left diastolic rapid filling phase. And as the 20% of the blood is gone, the mitral valve closes and diastole ends. So if you see these phases, there are two factors which are responsible for this normal diastole. One is the relaxation, which happened in the isovolumic relaxation phase. It is the ability of the myocardium to relax due to the removal of calcium ion from the myocardium, and also the compliance, the distensibility, the power of distensibility of the left ventricle, the relaxed left ventricle, in order to receive the blood from the left atrium. So this is called compliance. If relaxation and compliance both are normal, then there will be adequate LV filling without increased LV filling pressure at rest, as well as with exercise. But if there is a delayed relaxation, there is a reduced compliance of the LV due to stiffness, due to various causes, which I am going to show you and which I am going to discuss, there will be impaired LV filling in diastole, leading to increased filling pressure for a given volume. That leads to increased LA pressure. With LA remodeling, LA undergoes dilatation, it gets enlarged. And the LA pressure, since the LA pressure with LA remodeling occurs, that gives the back pressure, leading to pulmonary venous hypertension, and then patient goes into diastolic heart failure. So my patient was in this phase. He not only had the diastolic dysfunction, but he also had the diastolic heart failure. His diastolic dysfunction started from this phase where there was delayed relaxation. But after various, going through the these pathophysiological sequences, patient ultimately went into the diastolic heart failure. So this is the pathophysiology, and now let us look at the causes of diastolic dysfunction, where old age is at the top of the list. Mind it, the old age. In old age, the relaxation is always impaired. As the patient becomes older, over 45 years, even without any predisposing cause, there will be impaired relaxation. So we may get an impaired relaxation pattern in older patients, but the same pattern, if we get in the younger patient, is abnormal. But for an old man, getting an impaired relaxation pattern is a normal physiological finding. And the next cause is long-standing hypertension. Then cardiomyopathy, the myocardial disease, be it hypertrophic cardiomyopathy, restrictive cardiomyopathy, or infiltrative cardiomyopathy, you get some sort of diastolic dysfunction, some grade of diastolic dysfunction. Coronary artery disease leading to hypokinesia or akinesia or scarring. So all these are abnormalities of the myocardium, where the myocardium cannot relax. A scarred myocardium cannot relax, leading to diastolic dysfunction. Constrictive pericarditis. This is an extrinsic cause which hampers the compliance of the ventricle. It doesn't allow the ventricle, because ventricle is cemented with the calcified pericardium in constrictive pericarditis. So it becomes non-compliant. So that becomes a cause of diastolic dysfunction. Then obesity and sleep apnea. Now let us start with two-dimensional echo. Let us see how two-dimensional echo parameters help us in diagnosing diastolic dysfunction. Well, see, if we get this type of picture, or this type of picture, there are certain objective evidences of cardiac structural problem which will give you a clue that this patient might have a diastolic dysfunction. So one such is this disease. If you look here, look carefully, there is asymmetrical septal hypertrophy. So it is a case of hypertrophic cardiomyopathy, and also the left atrium is enlarged. And if we look at these patients, so hypertrophic myocardium cannot relax. And if you look at this apical four-chamber view, look at the LAD territory. It is scarred, it is akinetic. So this myocardium cannot relax. So this patient had an infarction in the LAD territory, indicating that this patient will have some grade of diastolic dysfunction. Well, leaving all these this type of objective evidence, the most robust indicator which we get in diastolic, the two-dimensional echo for diastolic dysfunction is the enlarged LA, left atrium, because enlarged LA is a marker of chronically raised LV filling pressure in absence of course, anemia, where we get enlarged LA. Also in atrial fibrillation, mitral valve disease, and in athletes. Athletes, we get normally enlarged LA. So now the question is, how do we measure the left atrium? Well, we always measure from the parasternal long axis, where we get a linear anteroposterior diameter. We measure in end systole. Anterior point is taken at the level of the midpoint of sinus of Valsalva, and the posterior point is taken perpendicular to the plane of left atrium. And these are the values. Now, see, left atrium is a chamber. It is a chamber, and according to the AAC recommendation, anteroposterior linear dimension should not be used as the sole measure of the LA size. Why? Well, here is the answer. See, there are caveats in the anteroposterior diameter measurement of LA, because if you look at this model, left atrium is an asymmetrical three-dimensional cavity. It does not enlarge consistently in all directions. Moreover, LA expansion in AP dimension, anteroposterior dimension, may be constrained by thoracic cavity between the sternum and the spine. So it may so happen that we are getting a normal anteroposterior diameter because the left atrium has enlarged in its superior inferior direction or medial to lateral direction. So anteroposterior diameter, it cannot be the sole measurement for LA dimension. We need to measure the LA volume. It is the LA volume index which is most robust cardiovascular risk marker than linear dimension to reflect the burden and chronicity of the elevated LV filling pressure. It is a strong predictor of outcome also. So it should be, measurement of the indexed LA volume should be a routine lab measure. So how do we do it? We measure LA volume from the two views, two apical orthogonal views. One is the four-chamber view, another is the two-chamber view. It is at the ventricular end systole, because that time the LA is having the maximum volume. We can use either the biplane area length method or biplane disc summation method, which is called modified biplane method. You must have heard this during the assessment of systolic function. Out of these two, disc summation method is preferred. So let us see how do we do it. We follow the several steps. First, we go to the apical 4-chamber view, freeze it, choose the LV and systolic frame, 1 or 2 frame before the mitral valve opens. So that time is the LA is in its maximum volume. We trace the inner border of the LA from one annulus and go round and round along the IAS, and then we take a round here without entering into the pulmonary vein. Here is the right pulmonary vein, and we go to the lateral annulus. So septal annulus to the lateral annulus. We don't join those 2 points, machine joins it. So first we get this area, and then a line comes, which is the length, and that length should be almost perpendicular to this interannular line. So and this here we get one area 1 and one length, and we then go to the apical 2-chamber view, and the whole thing is repeated where we get an area 2 and another length. Now, as I said, this length should be perpendicular to the annular plane. Now, so we are getting all these measures. Now the machine utilizes this formula, 0.85 into area 1 into area 2 divided by L. Now out of this 2L, the shorter value is taken, and we should be careful while taking this measurement of length, that is the L, because the difference of this L and this L should not be more than 10%. So we get a value, and then if we divide the body surface area with, if we divide that value with body surface area, we get the indexed LA volume, and the upper limit of normal is 34 ml per square meter. So now you see, look at this patient. Look at this patient where it is a case of the triple vessel disease, LV is dilated, and we measure the LA in the anteroposterior diameter, we get it is 3.61. But as we go to measure the LA volume index, we find that LA volume index is 35.3 ml per square meter using this summation method from 4-chamber and 2-chamber view. Now, so this is the fallacy. We cannot only measure the LA anteroposterior diameter. We need to practice it in every day in the lab. Just a second. So now we have to know how to measure the LA volume index. Now remember about this pitfall, which I already described you. If you look at this picture, this L is not perpendicular to the interannular line. So if you see carefully, 2 areas are dead here. One at the top in the corner, another at the bottom in the corner. So 2 areas of dead space are not calculated in the LA volume. So this is to be avoided. It is because of the foreshortening of the LA. So this is wrong, and this is the right approach. You have to be very, very, very careful. You have to be, your L value should be perpendicular to the interannular line. Now let us go now to the mitral inflow Doppler pattern. After the LA volume, this is very important. Now, how we do it? We go to the apical 4-chamber view, and we get the cursor. And where do we place the sample volume? We place the sample volume at the level of the tip of the mitral valve leaflets, not inside the left atrium, not inside the left ventricle. You will get wrong information. We will keep the sample volume at the level of the tip of the mitral valve leaflets in its open condition. Now, as we do the pulse wave Doppler, as I have already described while talking about the diastole, we get an E wave and A wave where E is more than A. Now, this is the normal pattern. Now, as the diastolic dysfunction sets in, as I have said, the LV relaxation becomes impaired. So the LV pressure fall is less. So when the mitral valve opens, the pressure difference between the LA and LV is less. So instead of 80% filling occurring during the early rapid filling phase, only 20% filling takes place, 20 to 40, and the rest goes to the left ventricle during the late rapid filling phase. So the E becomes smaller than the A wave. So, but the LA pressure is normal in this phase, remember. LA is not enlarged. LA pressure is normal. Now, as the disease advances, as the diastolic dysfunction advances, as I have already described you, over a period of time, the LA gets enlarged, LA pressure starts rising. So when the LA pressure moderately rises, what will happen? Again, the LA to LV pressure difference will be high. So a larger volume of the blood will go from the LA to LV, making the E wave again taller than the A wave. Now, mind it, this impaired relaxation pattern is hidden here. It is masked. This pattern is masked because of the raised LA pressure. Now, as the disease advances further, the LA pressure rises much more than that, becomes very high, and also LV becomes non-compliant. So what will happen? The LA pressure is very high, so as soon as the mitral valve opens, the blood flows with a high velocity. But again, the LV is non-compliant, so the early equalization of the pressure between the LA and LV makes the quick deceleration of the blood. So a tall E wave, but a very small amount of blood goes with a high velocity, and the rest of the blood should have gone during the late rapid filling phase. But A wave again is small. Why? This is because LV is non-compliant. So though the LA pressure is high, but it is like a balloon made of thick rubber. So though the LA is trying to push the blood, but since the LV is non-compliant, so it's unable to push it. So leading to a very small A wave. So tall E, short deceleration, and a small A with a very high EA ratio is the sign of restrictive filling pattern. Mind it, restrictive filling pattern, I have said, restrictive cardiomyopathy and restrictive filling pattern are two different things. So this is called a filling pattern of diastolic dysfunction, which is restrictive filling pattern. Now, so what we see, that relaxation abnormality is present in all grade of diastolic dysfunction. It is the raised LA pressure which masks the impaired relaxation pattern and gives us these patterns. Now, if you look, this pattern where E and A is E is more than A because of the raised LA pressure, and where normally E is more than A, looks so similar. So similar. Now, how to differentiate? Now, here you see a person is coming to the for heart checkup. Heart structurally is absolutely normal. He is normotensive, non-diabetic, non-smoker. E wave is more than A wave. But here is a patient. You see, there is an asymmetrical septal hypertrophy with the involvement of the mid-septum. Left atrium is enlarged. Here also we are getting E wave more than A wave. Now, which one is normal and which one is pseudo-normal? Well, obviously, this patient where LA is enlarged, myocardium is diseased, so this has to be abnormal, but it looks so similar to this pattern. So, what are the ways by which we can differentiate these two patterns? Well, there are two methods. One is the Valsalva maneuver, which reduces the preload in the LA. So what we do, we ask the patient to do the forced expiration with mouth and nose closed. And next is the tissue Doppler imaging of the mitral annulus. So I'm going to show you one by one. Now see, this pattern where the patient is a normal one and we are getting E more than A. And here we ask the patient to do the Valsalva. Look, with the Valsalva, both E and A wave velocities are decreased, keeping the ratio same. So this is the normal filling pattern. On the other hand, if you look at this patient where there is a hypertrophic cardiomyopathy with enlarged LA, the E wave is more than A. The patient does the Valsalva. Look here, E wave becomes smaller than the A wave. So this is obviously the pseudo-normal pattern. Now let us go to the tissue Doppler imaging. So what is the tissue Doppler imaging? See, so long we were measuring the Doppler velocity of the blood cells. In this TDI, tissue Doppler imaging mode, which the machine has, every machine has now, we measure the velocities of the tissues. We switch on a button, it colorizes the tissues. You see the myocardium, the leaflets, the annuli, the interventricular septum, interatrial septum, all are colorized with red and blue color. So it has colorized the tissues. Now for diastolic dysfunction assessment, we will measure the mitral annular velocity. So mitral annulus, here is the septal mitral annulus, and here is the lateral annulus. So we are going to measure the velocities of these diastolic velocities of these two annuli. Before measuring, we reduce the sector width to get a higher frame rate, which is necessary for tissue Doppler imaging. Now, normally, as you see the velocity, if you see the velocity of the septal annulus is more than 10 centimeter per second, and of that lateral annulus is more than 12 centimeter per second. So let us see how it goes. The normal patient, where the E wave was more than A wave, look here, tissue Doppler imaging. As you know, the mitral annulus moves towards the apex during systole and moves away from the apex during diastole. So if this is the baseline, that yellow line, orange line, the spectrums above the baseline are the systolic waves because annulus is moving towards the apex, and below the baseline are the diastolic waves. So now let us focus on the diastolic waves. The first diastolic wave is called E prime, which is denoted by E with dash. We say it E prime, and which is equivalent to the early rapid filling phase, that is the E wave. And A prime, it is not the blood flow, it is the annular motion which we are looking. And A prime is occurring during the late rapid filling phase. And it is the second diastolic wave. So E prime is more than the A prime, both in the septal annulus as well as in the lateral annulus, which is quite normal. In the septal annulus, the velocity is around 8.5, which is quite normal. And in the lateral annulus, it is around 12 centimeter per second. Now, let us look at that patient of hypertrophic cardiomyopathy, where E wave is more than A wave. But here you look, the tissue Doppler is showing E prime less than the A prime. both in the septal annulus as well as in the lateral annulus. So this is the way we differentiate. So this is the pseudo-normal pattern having E prime less than the A prime, though the E wave is more than the A wave. So these are the two methods by which we can differentiate the normal from the pseudo-normal pattern. Now, when I talk you about the tissue Doppler imaging, a ratio, I have to mention about a ratio which is very important to predict the LV filling pressure. The ratio of E by E prime. So E wave velocity is from the mitral Doppler and the E prime from the mitral velocity, fast as velocity. So we take the ratio once in the septal annulus and then again on the lateral annulus. So that ratio is called E by E prime ratio. So in that hypertrophic cardiomyopathy patient, in the septal annulus, E by E prime is 24. And in the lateral annulus, it is around 15 E by E prime. So we take an average of these two values, which turns out to be 20. So as per the latest AC guidelines, if the average E by E prime is more than or equal to 14, it predicts the raised LV filling pressure. So normally it should be less than 8. So once it starts to be close to 12, 13, 14, we become very, very careful. So if it is more than or equal to 14, the LV filling pressure is definitely high. So this is the way we calculate the E by E prime to predict the LV filling pressure. Now, another criteria is looking for tricuspid regurgitation jet velocity to indicate the status of LV filling pressure. Here you see there is a small tricuspid valve regurgitation. See, this is the RV modified view. And then I get the cursor and I get the continuous wave Doppler to get the tear jet velocity. You know that around 90 to 95% normal population has some mild tricuspid valve regurgitation. But that normal peak tear jet velocity should be less than or equal to 2.8 meter per second. But here in this particular case, the velocity is 3.15 meter per second, which is high, which shows the patient is having pulmonary arterial hypertension, with a gradient of 40 millimeter of mercury of the tear jet. So the raised pulmonary arterial systolic pressure from the peak tear jet indicates that the patient is having elevated LV filling pressure. Now, so far, what are the parameters we have come across? One is the LA volume index. Then we have also seen the velocities of the E wave and the A wave, EA ratio. We have seen the septal E prime and the lateral E prime velocities. Also, we know how to measure the E by E prime ratio. And also we have seen the tear jet velocity. Now, utilizing these criteria, the AC has given us how to diagnose diastolic dysfunction in a patient with normal LVF, or how to grade the diastolic dysfunction in a patient with myocardial disease with normal or reduced LVF. Now, see, what is there in the guideline? There are 4 criteria. One is the average E by E prime, which you have already, I have described. Second is the septal E prime velocity. It should be, if it is less than 7 centimeter per second, or lateral E prime velocity less than 10 centimeter per second. Number 3, tear jet velocity more than 2.8 meter per second. Number 4, LA volume index more than 34 ml per square meter. Now, out of these 4, if more than 50% is positive, that means 3 criteria are positive, then we say the patient is having diastolic dysfunction. If less than 50% positive, then we say it's normal diastolic function. The patient is having normal diastolic function. If the 50% is positive, like 2, then we say it's indeterminate. So this is the chart given by AAC. Now let us see how we grade the diastolic dysfunction with the myocardial disease. In a patient with the myocardial disease, either with normal EF or with reduced. Just excuse me, I'll drink a little bit of water. Okay. So now look at this flow chart. Here is the mitral inflow. All will see the mitral flow pattern, tear, LA volume, E by E prime, all those. Now let us concentrate on the left arm of this flow chart. Here is the mitral inflow. If E by A ratio is less than or equal to 0.8, along with E wave velocity less than or equal to 50 centimeter per second, straight away you can see it's a grade 1 diastolic dysfunction with normal LV filling pressure or normal LA pressure, more or less same it is. So patient, you don't have to go to the further detail. You can see, but we always do to double check. But you can say if you get this pattern that the patient is having grade 1 diastolic dysfunction. Here is a patient, you see 60 years old male, came for a routine checkup with a history of hypertension for 1 year, non-diabetic. Now, this is the apical flow chamber. I have kept the sample volume at the level of the tip of the mitral valve leaflets to do the pulse wave Doppler of the mitral flow, when I gave the E wave 48 centimeter per second and EA ratio 0.6. So I can straight away say it is a grade 1 diastolic dysfunction with the LV filling pressure normal, because E wave is less than 50 centimeter per second plus EA ratio is less than 0.8. And we check the LA volume, it's 28 ml per square meter. So it is much less than 34 ml per square meter. And also we see the average E by prime, it turns out to be 7.4. So it is a grade 1 diastolic dysfunction. Now let us look at the extreme right arm of the flow chart, where E by A ratio, if more than or equal to 2, you can straight tell that it is a grade 3 diastolic dysfunction with raised LA pressure. And this grading is done where there is myocardial disease, not in normal young individual, where normally you may get E by A ratio more than 2 because their LV relaxation in the younger people is vigorous. So that gives rise to a very tall E and small a. So don't consider that this is applicable for young individual where there is no myocardial disease. This is for a patient who is having myocardial disease with either normal or low EF. So E by A ratio of more than 2, you can say that it's grade 3 diastolic dysfunction with raised LV pressure. Here is a patient, see, 56 years old male, hypertensive, non-diabetic, complaining of shortness of breath for 6 months in class 2 to 3, bilateral ankle edema, hepatomegaly, crepitations. Look, LA enlarged, there is thickening of the myocardium. This is a patient of cardiac amyloidosis. If you look at the myocardium, it is a very peculiar character. I mean, so the speckled appearance of the myocardium. But anyway, there is a small pericardial effusion also. So what we do? We do the diastolic function assessment. Look at the mitral E wave. Very tall E wave and a very small A wave, almost not there. With an EA ratio 6.6. So LV filling pressure is elevated if EA ratio more than 2. And this is a grade 3 diastolic dysfunction with a restrictive filling pattern. As I have already told you, this is not applicable in healthy young individual with normal myocardium, normal EF. So EA ratio, if more than 2, in a patient of myocardial disease with normal or reduced EF, indicates that LV filling pressure is raised and patient is in grade 3 diastolic dysfunction or restrictive filling pattern. And what is the E by E prime? Look, here E wave is very tall, and as I do the tissue Doppler imaging of the septal annulus, I get very low tissue velocities, both in diastole and systole, both in the septal annulus and the lateral annulus, with the average E by E prime ratio of 44.6. Very high E by E prime. The patient is in grade 3 diastolic dysfunction, a patient of cardiac amyloidosis. And now let us look at these are middle arm of mitral inflow pattern. These are the patterns we get every day, many cases, either these or that. So you have to know all these patterns. Depending on the diseased condition, the Doppler pattern of the mitral flow varies. Now, if you happen to get a filling pattern where E by A ratio less than 0.8, plus E wave velocity more than 50 centimeter per second, or E by A ratio more than 0.8 but less than 2, you have to evaluate 3 criteria. What are those 3 criteria? Now, number 1, average E by E prime more than 14. Number 2, TR velocity more than 2.8 meter per second. Number 3, LA volume index more than 34 ml per square meter. You know, all of you now know, I have already explained how we do this, how we get all these values. Now, after getting these 3 values, you will come to the conclusion. Now, out of these 3, if 2 or 3 are negative, then you can straight away tell that it is a grade 1 diastolic dysfunction. On the other hand, if 2 or 3 are positive, then you say it is a grade 2 diastolic dysfunction. But say suppose patient doesn't have any TR, you can't see TR. So there are only 2 criteria. Out of those 2, if 2 are negative, then it is a grade 1 diastolic dysfunction. If 2 are positive, then it's a grade 2 diastolic dysfunction. And if 1 is positive and 1 is negative, then you cannot determine the LA pressure or diastolic dysfunction grade. Now let us see. See, this is a case of hypertrophic cardiomyopathy. As you can see, LV is very much hypertrophied. Whole septum is hypertrophied, LA enlarged. And you are getting a E by A ratio less than 0.8. Here it is 0.7. Plus E wave velocity, in this case, is 99 centimeter per second. And so it's full filling. And you cannot say that this is, though the E wave is less than A wave, you cannot say that this is a grade 1 diastolic dysfunction or grade 2 till you see the other findings, which I'm going to describe, you need some additional parameters. So this pattern where E by A ratio less than 0.8 and E wave is more than 50 centimeter per second, you cannot determine the LV feeding pressure, neither you can grade the diastolic dysfunction. And then situation 2, you see, this is a case of LAD infarction. Look, the apex is scarred and akinetic with a thrombus in it. Here, look, EA ratio, though the E wave is more than A, but the ratio is 1.38, so it is in between 0.8 to 2. So here again, LV filling pressure is uncertain to comment, and also the grade of diastolic dysfunction. We need the additional parameters. So what are those parameters? I have already told you. The tissue Doppler imaging, tissue Doppler average E by E prime, using the tissue Doppler imaging more than 14. So this first case is fulfilling the criteria. 20.7 is the average E by E prime. So one criteria is done. Now let us see the TR. TR gradient velocity is 1.4. So this is not getting fulfilled. Number 2 criteria is not fulfilled. And number 3, LA volume index is 35 ml per square meter. So out of 2 criteria are fulfilled. So it goes into grade 2 diastolic dysfunction. And then let us go to the, as I said, 1 positive, 1 negative. You cannot determine, and you may look for the pulmonary venous systolic diastolic wave. Here is the way how to look for the pulmonary venous flow pattern. The apical 4-chamber view, it's difficult to image pulmonary vein because it's a posterior structure, and you see this posterior part of the of this sector. But nowadays you can get with the good machines. You place the sample volume inside the pulmonary vein and you get the systolic wave and diastolic wave. Normally systolic wave is more than the diastolic wave with a ratio more than 1. But if the patient is having reduced ejection fraction, you may get systolic wave less than the diastolic wave. The ratio is altered. So ratio is less than 1. But it is again a challenge, suboptimal image quality. In this particular case with reduced ejection fraction, I'm getting this pattern. But remember, this is not applicable in healthy young with normal LVEF. A bit about the isovolumic relaxation time. As you know, isovolumic relaxation time is an important measurement in assessment of diastolic function. So aortic, it is the time between the aortic valve closure to the mitral valve opening. We get this value while doing the Doppler from the apical 5-chamber or apical 3-chamber, keeping the sample volume of the cursor in between the mitral and the aortic. And as we do the pulse wave Doppler, we not only get the mitral inflow pattern, we also get the LV outflow pattern. Now, as I said, the isovolumic relaxation time is the time from the aortic valve closure to the mitral valve opening. So as you know, this is the E wave and this is A wave. So here mitral valve opens and here the aortic valve closes. So after the aortic valve closure till the mitral valve opening is the isovolumic relaxation time. So I'm measuring here and I'm getting it 66.54. So normally it is less than 70 millisecond. It is measured in millisecond. It is inversely related to the LV filling pressure in diastolic dysfunction. It becomes prolonged with normal LV filling pressure. I mean, if you get a higher value, the LV filling pressure is normal. But if it is a short, less than 50, it indicates that LV filling pressure is high, because because the mitral valve opens quickly. Now, challenge is the tachycardia. Another criteria is the color and mode propagation velocity. There are too many things, but you have to know the things. But to start with, these are the very easy stuff, but you can always do. These are available in every machine. So what it is, color and mode propagation velocity. Since so long we were measuring the pulse wave Doppler across the mitral valve or tissue Doppler imaging. Now here we are, you see the blood is flowing from the LA to LV, that red flow. Now following this cursor, you see here along this cursor we will do the M mode, motion mode, instead of pulse wave or CW Doppler. As we do the M mode, see, you can see the mitral valve opening here. See, this is the mitral valve tissue, white line, thin line, here and here. And the blood flows from the base of the LV towards the apex with the slope. So, if the relaxation is normal, this flow within the LV is very steep, very fast blood flows. The LV sucks the blood from the left atrium almost to the left ventricle. So making this slope very steep. And normally if we measure this this slope from the level of the mitral valve up to the 4 centimeter inside the ventricle, this is the LV inside. Mitral valve is here and this entire is LV. So we go up to 4 centimeter and we measure the slope. Normally it should be more than 50 centimeter per second. So that is called VP. VP means propagation velocity. But in all other patterns of diastolic, grades of diastolic dysfunction, it is less than 50 centimeter per second. Here it is 163 centimeter per second. So the LV is relaxing very nicely. On the other hand, if you look at this, look biatrial enlargement, it's a case of cardiac amyloidosis. Look here, the VP is only 29 or 30 centimeter per second. The slope is so slanted. So here color and mode propagation velocity is very, very low, indicating that the blood is not flowing. The LV relaxation is very highly impaired, and as a result of which blood is flowing slowly from the base to the apex. So this particular criteria is having low feasibility and reproducibility, but still you can do it. And there are two certain things which are useful in presence of AF. If E by VP is more than 1.4, it indicates raised LV filling pressure, or E by VP more than 2.5 predicts the PCWP more than 15 in patients with reduced ejection fraction. Now, see, so long we were talking about the diastolic function assessment at rest, but there are certain group of patients who, in spite of being in the grade 1 diastolic dysfunction, where LA pressure is supposed to be normal, but the patient goes into heart failure, shortness of breath, as he or she does the exercise during morning walk or evening walk. The patient cannot walk up to certain distance. This is because patient goes into heart failure. So in this case, in this particular group, we go for diastolic stress test. Well, what is that? It is the measurement of the LV filling pressure by echo with exercise. So long we were measuring the LV filling pressure at rest. Now we'll measure with exercise, because the reason why we do it will be very clear if you look at this chart. Now normally, it is green color indicates the normal people, At rest and exercise, at both stages, the LV filling pressure is normal, much below 15 millimeter of mercury. With advanced HEPF, heart failure with preserved ejection fraction, LVDP is high both at rest as well, and it increases further with exercise. So no problem in diagnosing these cases, because at rest also LV filling pressure is high. But those who are in early HEPF, their LV filling pressure at rest is normal. But as they do exercise, the LV filling pressure rises and patient goes into heart failure and shortness of breath. Why this happens? Because if you look here, in a normal subject, if you look at the effect of exercise on diastolic function of the LV, in a normal subject, the LV diastolic function is augmented. The myocardial relaxation becomes augmented with exercise, with more powerful early diastolic suction, as a result of which E wave becomes further taller. So also the E prime, because myocardial relaxation is augmented. On the contrary, in those patients who become symptomatic with exercise, but at rest, normal LV filling pressure, there is no augmentation of myocardial relaxation, and the required cardiac output is achieved at the expense of increased filling pressure. So though the E wave becomes tall, there will be no change in the E prime, because no augmentation of myocardial relaxation. So E prime remains short, so making the value of E by E prime very high, raised LV filling, indicating raised LV filling pressure, and that is why the patient goes into shortness of breath. We do it in our lab. So this is done. See, at rest, we do in the step 1, we get all the diastolic parameters, save those in the machine, ask the patient to walk on the treadmill belt, and as the patient becomes symptomatic, the patient quickly lies on the bed at the end of the exercise, and we take the diastolic parameters once the patient lies down in the bed. One difficulty is that because of the tachycardia, as the patient exercises, there's a merge of E and A wave, so E-A ratio becomes problem. But if you wait for some time, few seconds, half a minute, the E wave, A wave gets separated, but the diastolic dysfunction persists for some time, so there's no problem. You can get the values. Look here, at rest, E wave was this much, at stress, E wave became taller, but look at the E prime, it has gone, it has become shorter. So E by E prime at rest, which was E by E prime, which was 9 at rest, and becomes 17.6 with stress, indicating the patient developed diastolic heart failure with exercise. The same result you may get with passive leg raising test. Here we have an advantage because heart rate is not increased, and it is favorable for keeping the E wave and A wave separated. So what we do when you are assessing the diastolic dysfunction, where patient is lying on the bed, you just elevate both the legs passively to about 70 to 80 degrees. It will increase the preload transiently, and if the patient was not having raised LV filling pressure in flat position and with raised leg, it may unmask the elevated LV filling pressure, resulting in E by E prime ratio more than or equal to 14. Now these are the methods we use, and there are certain advanced techniques for assessment of diastolic dysfunction, where we do the LA strain. LA strain is an important biomarker of HEPF. It improves the diagnostic accuracy. It is a good prognostic marker. We look at the reservoir strain. However, at your level, these are taught in advanced course. So you will learn during the advanced course. So in conclusion, I would say that assessment of diastolic function is one of the most critical part of the echo examination, as you have understood in this 1 hour discussion. So it should be done carefully, keeping it very simple and following the algorithm and guidelines. Thank you.
Thank you, Dr. Debika. Excellent presentation covering virtually right from 2009 to 2016 and up to 2023, looking at the LA strains. Let's understand from our students how much they have appreciated the diastolic function, or they have gone into diastole already. So can you, somebody who wants to ask some question, can you raise your hands up for your queries and questions? So Dr. Naik, Muzaffar Naik, please go ahead.
Thank you, sir. Thank you, ma'am, for our excellent presentation.
Okay, thank you.
You mentioned that while evaluating diastolic dysfunction,
Yes.
we grade them grade 1 and grade 2 and grade 3, and we use E by E prime of more than 14 or a TR velocity of more than 2.8 and a LA volume index of more than 34. Can you, ma'am, please explain me when we use that IVRT or propagation velocity in diastolic dysfunction? Do we use it routinely, or is it just an corroborative evidence?
See, IVRT you can do routinely, and M-mode propagation velocity, as I said, it's not used routinely, but yes, you can do it. We do the other criteria routinely: E by A, velocity, A wave velocity, NA volume index, E prime velocity, A prime velocity, E by E prime, and TR velocity. These are done routinely, and also you can look at the isovolumic relaxation time. Also, it helps you. It helps you when suppose you are not getting all the criteria clearly. So there you are in a position where you cannot classify. So use these additional parameters.
So they serve as a corroborative evidence rather than for grading diastolic hypertension.
Yes.
Dr. Muzaffar, in today 2025, we look at 2016 guidelines, EA ratio, E prime septal, E prime lateral, average of E to E prime, LA volume index, and TR jet velocity in normal LV systolic or abnormal LV systolic functions.
Okay.
Now the question comes when you are uncertain, especially in abnormal, then you look for LA strains. These IVRT, flow propagation velocity, they are used in other conditions which are non-cardiac, like valvulars.
Okay.
Hypertension with hypertrophy, pulmonary artery hypertension. In those conditions, we switch over. I'll just say in simple word, once you look for a cardiac conditions, it is 5 parameters: EA ratio, E prime septal, E prime lateral, E prime E2 prime average, LA volume index, TR jet velocity. And finally could be LA strain. If you're looking for a non-cardiac pathology like valves, pulmonary artery hypertension, hypertensive heart disease, use these parameters of IVRT, flow propagation velocities. These are the factors which are used in those circumstances.
Thank you, sir.
So let's go ahead with Dr. Shantanu Pramod Mal. Dr. Mal, go ahead and ask.
Good evening, ma'am. Good evening, ma'am. Thanks for the wonderful and elaborate talk on diastolic dysfunction. My question was just to simplify the talk, ma'am. When we are by the machine and leaving aside other parameters because they are straightforward, when it comes to putting across the pulse wave Doppler across the mitral wall, when we have the graph of the E wave and the A wave in front of us, practically what should be the approach when we look at the E wave and A wave to start with? And from there, when should we go towards the TDI? Like practically, what do you usually follow in the course of steps by the machine? If you can just help us with that particular flow of working, that'll be great, ma'am.
Okay, Shantanu, see, everything starts from the clinical background. You take the history, very short. I mean, while starting the echo, you must go through goes through the history of the patient and a little bit of physical findings. That is must. Little bit of auscultation. What he is suffering from? Is there any background where the patient might have the diastolic dysfunction? Well, after that, you start with two-dimensional echo, where you get certain clues, as I said, the hypertrophy, the LA enlargement, LA volume index. Then you go to the diastolic parameters. Very fast you can move. See, though I have elaborated very slowly, but we do it very fast here. Once you become expert, quickly you can do the 2D examination, LA volume index measurement, then directly you go for the diastolic parameters. And then you start assessing the E and A. And of course, routinely we do the tissue Doppler imaging. Though you can directly go to the classification of grading by the EA ratio. However, we do it regularly, the tissue Doppler imaging, since all the machines are having the TDI facility now. So why don't you try it? I mean, you have to do it in each and every case. So these are the few steps. If you follow the algorithm, always start with two-dimensional echo. Never jump to the diastolic pattern. Never. First, you assess the two-dimensional echo. Always look at the left atrium. As I said, it's second chronic marker of the raised LV filling pressure. And also you have to look the scarring, the hypertrophy. There are various myocardial diseases which you can diagnose just by looking at the two-dimensional echo. After that, you start doing the Doppler. Okay? Very simple.
Okay, ma'am. Thank you.
Two-dimensional history, examination, little bit. Two-dimensional echo, Doppler echo, tissue Doppler.
Dr. Mal, when I'll show you a live demonstration, I'll show you how quickly you can do all these things.
Perfect, sir. Thank you so much. Will be great.
Because it takes about 2 minutes, maximum 2 to 3 minutes to do it.
Sir.
And we have to learn in 2025. Don't have to learn in 2022 or
Yes,
2002.
Sir.
All right, Dr. Veena Bang, go ahead.
Ma'am, I wanted to know that how to differentiate between normal and the pseudo-normal diastolic dysfunction with Valsalva.
Yes. See, we ask the patient to do the forced expression as you do in the Valsalva. So start the pulse wave Doppler across the mitral valve. Ask the patient to do the Valsalva. As the patient does, in a normal patient, both the velocities of both the E and A wave will be reduced. So that will keep the EA ratio same as at rest and with Valsalva, right? Clear?
Okay, yeah, ma'am.
Yeah, now it is a pseudo-normal pattern. Suppose in the pseudo-normal pattern, there is a hidden impaired relaxation pattern, right? You agree?
Right. Yeah.
So you ask the patient to do the Valsalva. So at rest, E wave is more than A. With the Valsalva, you are reducing the preload. So the impaired relaxation pattern now will be unmasked. So now the E wave will be smaller than the A.
Right. Yes,
Yeah?
ma'am. Got it.
So while doing the pulse wave Doppler, you ask the patient to do the Valsalva manual.
Okay. In normal, both will be reduced in equal proportion, and
Yes.
in pseudo-normal, A will be the same and E will be reduced. So it will be like nearly the same.
No, the A wave will be taller.
A will be taller than E wave.
Yes.
Yes, ma'am. Okay, thank you.
The impaired relaxation pattern will be unmasked.
Yes, ma'am.
Very simple, Veena. Ask the patient to hold his breath.
That is the
Keep on looking at the mitral flow pattern. Patient will automatically go into Valsalva. At one time will come, he will start holding his breath, trying to hold his breath. In that fashion, you will not lose your Doppler spectrum pattern.
exactly.
Yes.
Because if you
Thank
know your Doppler spectrum pattern, you cannot compare. So remember these questions when I'm showing you live demonstrations.
Sure, sir. Sure. Thank you, sir.
Anybody else? I hope all of you are not in diastology.
Yes, diastole is like that.
Diastole is like that only. At least you are awake. Majority of people, they sleep.
A phase of rest.
Sir,
Go ahead, Kamal.
good evening, sir. Sir, we have to look for septal and lateral, both E prime,
Correct.
or both are to check.
Right.
Lateral and septal. Okay. Okay,
Because
then.
you are going to take the ratio of septal. You have to add septal and lateral E by E prime to get the ratio, average ratio.
Majority of machine they give you automatically today.
Okay, sir. Thank you.
Majority of machines.
Okay, sir. Thank you.
All right. Anybody else? Dr. Chirag, you are looking very beautiful today. Some anniversary or birthday? Chirag Gurbani.
Yes, sir.
Some birthday or marriage anniversary today?
No, sir.
But you're looking very like you have switched off your camera, but you're looking very nice today, man.
Sorry, sir.
So if there's no more questions, shall I go ahead and do my job? So I'll just put this on a recording stop. And thank you very much, Debika, for taking your time out from a busy schedule as usual. And she's a wonderful person. Anybody living in Calcutta can go and meet her in NH National Narayan Hridayalaya RNTI Hospital. And she'll be really helping you all the times. If you happen to come to Delhi, you are most welcome to visit us at any time. Of course, you'll be visiting to us in the month of November. Apart from that, anytime you can come to us. With these few words again, let me pay thanks to Dr. Debika Chatterjee for taking excellent deliberation on basics of diastology. And that's all I would say. Thank you, Debika, again. And I'll put this on a stop.